Hey guys, Woodruff here, and today we're going to talk about diabetes. So this is my actual lecture that I do in my class. Obviously, my actual lecture in class has a little bit more I was going to say thrills, but I don't think the students would call them thrills, but they have a little bit more to it. So this is just the bare bones PowerPoints, but it's a little bit more expanded for those that feel like the videos or maybe they need a little bit more, or in case we miss a lecture, that you can always refer back to this because I do talk a lot and talk fast. So this will be a little bit more in depth for those that are looking for more in depth. So I'm going to try technology. So starting to talk about diabetes. So diabetes, and this is something that a lot of times students struggle with, is like, what is it? And so diabetes is it's a disease process that affects the whole body. And so the big thing with diabetes is it's not just about like, hey, I have too much sugar in my blood. That sugar in the blood affects the whole body and we're going to talk about here in a minute about how it affects the blood vessels, but it affects the blood vessels. Therefore, where are there blood vessels? There's blood vessels everywhere. So we really get concerned about patients with diabetes because there's so many parts of their body that can be affected. And the problem here is either they're not producing enough insulin, or I should say they're not producing any insulin, they're not producing enough insulin, or insulin is not getting, I should say, glucose into the cell. So in other words, there's a problem where we can't get glucose, which is our energy source, into the cell. And as a result of that, it can lead to a lot of problems, which we'll talk about. Diabetes is the 7th leading cause of death in the United States, which is why we have kind of a whole section on it. And it's probably going to be one of the most common things you're going to see people diagnosed with when you're caring for patients. And as a whole, like, there's a variety of causes. We're going to talk about type 1 versus type 2, but there can be genetic causes, there can be autoimmune causes, and there also can be environmental causes as well. So, 1 second. All right, I'm back. So I usually like to show a video after this, and that's why I paused it, because I was thinking about showing the video, but I think because of copyright or other things, I don't know if I can really show it. So, but just know that it really helps to find videos that kind of bring this stuff together to kind of get an idea of what this is. But let's talk about more kind of going in depth, and I'm going to do my best to describe kind of what the video would show. So we're kind of talking about what's the big deal? What's the big so what about not having enough insulin, not having any insulin, or not being able to get glucose into the cells? So what the video describes or goes into is it really talks about the fact that effectively glucose is the energy source for our body. And so if I'm not getting glucose into my cells, my body doesn't have energy. And so obviously that leads to exhaustion, organs not functioning the way that they're supposed to, etc. But it also leads to glucose being in the wrong places, and which we'll talk about what the consequences of that are. But effectively think of insulin like a key, and it's a key to get glucose into the cell. And usually when your body's working the way it's supposed to, you have an equal number of keys or insulin to get glucose into the cell as you do glucose. So in other words, like for every glucose cell, there's enough insulin to get it in. But if I have a problem where I don't have enough insulin, like I'm low on insulin, or if I'm making no insulin, then I don't have that key to get glucose into the cell. So if glucose doesn't have a key, it's just going to be hanging around in my bloodstream. And you may think like that's where we want sugar, but sugar in the bloodstream is not helpful. Like it says down here, it irritates blood vessels. It literally starts breaking down the lining. It dehydrates cells, because what happens is when all the glucose is in the blood, the cells, like all the water that's in the cells is like, hey, there's a lot more stuff going on out here in the bloodstream. I'm going to leave the cell and go hang out in the bloodstream with all that glucose. So effectively, think of it kind of like a leech, like the glucose in the blood leaches water from the cell. And so it dehydrates your cells, and then leads to this, like, that's why, we're going to talk about it, but patients that, go into diabetic crisis, or patients that have diabetes a lot of times show up with polyuria and polydipsia, which is they're really thirsty and they're peeing a lot, and they're really thirsty because their body feels like it's dehydrated because those cells are dehydrated. And then you're peeing a lot because when your body pulls all of that water from the cell into the bloodstream, then you end up effectively getting to the state where like your body's like there's too much of something, so it tries to get rid of it. So you're really thirsty and you're peeing a lot because your body's getting rid of this water, leaching out of the cells and then peeing it out. And like I mentioned, your body also can't function because it does not have energy, but effectively you don't have enough keys to get glucose into the cell. Glucose is running rampant in the bloodstream. It's breaking stuff down, it's dehydrating you, and you don't have the energy that you need in order to function. But you know, we'll talk later about the other consequences and stuff of the irritation of these blood vessels, because that's where a lot of the complications come up. So what's the big so what? So like I was talking about consequences. So glucose in your bloodstream can lead to a lot of problems. You're going to have a significantly higher risk for cardiovascular disease, because a lot of cardiovascular disease are all based in how are my blood vessels doing. If my blood vessels are getting broken down by sugar, I'm going to be in a lot of trouble. These patients are also at higher risk for infection in general, and they're at higher risk for infection for a few reasons. One, if you have a lot of sugar in places that normally you wouldn't have a lot of sugar, it's good to know that anywhere that there is sugar, bacteria love sugar. Bacteria literally feeds off of sugar. So they're going to be at higher risk for issues with getting infection for that reason alone. But also people with diabetes have a decreased immune function. Like they don't have as much of a, like what we call a mobilization of their white blood cells. And what that means is that effectively, think of it kind of like if every time you got an infection, it was a battle. That what happens is that, like for me, I have a healthy immune system. I don't have diabetes. So when I get an infection, my immune system's like, let's go get this thing. Like I'm going to go beat this thing. Whereas like with people with diabetes, their immune system's kind of like, hey guys, I think something's going on over here. Do you think we should go? Well, okay, all right, well, let's go. Like, you know, it just takes a little bit more time. So it has less of an immune defense, and you're going to be a lot more prone to infection as well. So effectively, I'm going to be more prone to getting infections, and I also don't have the same like oomph or the same amount of force to fight infections. So infection is going to be a very big risk. The probably top two problems aside from cardiovascular disease and infection are going to be blindness or eye problems. And we'll talk about this in complications more, but because of the blood vessel irritation, it can break down those blood vessels. And then also the kidneys are very, very sensitive and have a lot of vascularity, or they have a lot of blood vessel. They're very dependent upon the flow in the blood vessels, but they also are very vascular, or they're made up of a lot of blood vessels, so they can have a lot of damage as well. So as a whole, it's all about the decreased blood flow to the organs and to the nerves, which leads to lots of perfusion problems. And you'll find out when I teach you about cardiac how much I love perfusion. So who's at risk for diabetes? Anyone who's over 45 is going to be at a greater risk for diabetes. If you have a BMI or a body mass index greater than 25, anyone with a first-degree relative with diabetes or a family history is going to be more at risk. Having a sedentary lifestyle or not being very active is going to increase your risk. There's certain ethnicities that are going to be more at risk, especially those of Hispanic origin, Native American, African American, Asian American, and Pacific Islander are higher risk. Anyone who's had a gestational hypertension or a larger infant, that would be classified as infant greater than 9 pounds. Anyone who also has cardiovascular disease, you know, sometimes it's like which comes first, the chicken or the egg? Is it the cardiac problems that come first and then the diabetes, or does the diabetes come first and cause the cardiac problems? And sometimes we'll never know. We also look for insulin resistance, what's known as acanthosis nigricans, and obesity are going to both be signs of insulin resistance. And I'm not saying just being obese means you're insulin resistant, but being obese does affect your the way that you can utilize insulin. And a lot of people that are obese have insulin issues. So if you don't know what acanthosis nigricans is, it's a darkening. It shows up usually in you know, like folds areas. So it shows up here in the back of the neck. It can show up in the armpit. It can show up in like the groins. Think of like, I want to say flaps. We don't really have flaps, but folds of the body. It's like a darkening of that area, and that's a sign of insulin resistance. And to kind of tell a really quick story, you know, when I was in my nursing school, yes, I survived it, so you can too, is that I had to do a project for community health where I was at a elementary school. And so the nurse was like, I had to kind of find some students that were at risk for something and teach them something. And she's like, hey, well, you could look through and see how many students have this acanthosis nigricans and teach them about diet and stuff, for diabetes. So I figured in an elementary school, there has got to be minimal students that have this, but you would be so surprised. And there were students in kindergarten, first grade, that had signs of insulin resistance already. Now, some of that's going to be genetics, but a lot of them were already obese or had a very high body mass index as well. There's also what's known as PCOS or polycystic ovarian syndrome that affects insulin resistance that also puts them at high risk. So let's talk about the difference between type 1 and type 2. So type 1 diabetes, this is a pancreas problem. There's something going on in your pancreas, and it may be a genetic, like some people's, it's like they believe it's an autoimmune process or viral origin, because a lot of times a virus comes right before patients are diagnosed with this. Pretty much what's happening is that you have little or zero insulin, which means you have too much of the sugar. We already kind of went into that. But think of it this way, is that effectively something's going on with the pancreas where you do not have those keys to get glucose into the cell. And the other difference is it's usually very abrupt. It comes very suddenly versus gradually over time. And it's really important, understanding, there's not going to be a lot of test questions that are, going into causes and stuff like that. But when you're thinking of type 1, the thing you need to remember is that these patients will always need insulin. We're going to talk about with type 2, there's sometimes lifestyle changes, other things that can happen. This is not a lifestyle issue. This is my pancreas is not functioning issue. And so because of that, I have to have insulin. I need to replace what's missing. I'm missing insulin. I need that. So whereas we're going to talk later about patients with type 2 diabetes can be managed without insulin. They can sometimes take oral medications, or they can just change their diet, or they can exercise more and they can see a great improvement. These patients, we can do all that. It's not, and we're not going to tell them don't do it, but it's not going to make a difference because for them, what they're missing is insulin. They need the keys. They need that key to get the glucose into the cell. That on the other hand, let me get far ahead of myself. Let's talk about how they present or how they show up. So usually what's most common for these patients is they're going to show signs of hyperglycemia. We talked about some of these. It's the 3 polys, and there's polyuria, which means I'm peeing a lot. There's polydipsia, which means I'm thirsty. I always think the D for I want to drink. I want to dip, dip my, I don't really want to give this, let me tell the story first, because otherwise this is going to sound really crazy. The polydipsia, sometimes when patients are super thirsty, I've had patients before that will literally drink out of a toilet. So, so maybe remember polydipsia because they're going to dip their head in the toilet to drink that water. They are so damn thirsty. And then there's polyphagia. And I remember the PHAG is like phagocytosis, which is eating or chomping. So polyphagia is when they're hungry. And the urea, if you can remember, like urine. So they're peeing a lot, they're thirsty, and they're hungry. Remember, they're peeing a lot because the glucose is dehydrating their cells, and then their body's like, hey, I have too much water, and it's peeing it out. The polydipsia is a result of that their cells are getting dehydrated. And the polyphagia is because they don't have glucose in the cells. So their body's like, I'm hungry, give me glucose. Even though they're full of glucose, it's not where it needs to be. So they still have that sensation of hunger. So they might also have systemic symptoms. These aren't as common in type 1, but they can happen. They may have troubles healing, or they're often getting sick. They may be losing weight. And so that's another thing that's different about type 1 is a lot of these patients, like most people see diabetes and think it must be someone who's like eating too much, etc., just not managing their life or their lifestyle well. Let me take a little sip. But as a whole, a lot of times with type 1, the issue is all in the pancreas. So a lot of these patients can actually be the opposite, and they can be super skinny and have some issues with being nourished as well. They can also show signs of complications like having altered vision or numbness and tingling, sensory changes, etc. So now let's talk about type 2. So type 2, the difference here is that in type 2, this is a cell problem. So it can be a pancreas problem too. Sometimes their pancreas is not secreting as much as it needs to. But think of it this way, is that this is more a problem where the cell is overworked and it just quits. It's like, I've had too much. So, anytime that there is the body's doing a process over and over, eventually it can kind of get tired, or it can do what we call down regulation, where it's like, man, like I'm doing this so much, I'm not going to produce as much of something. So sometimes the body is just like, it's exhausted. It's like, man, they're eating so much sugar and I'm producing all this insulin. It just gets tired. It doesn't want to do it anymore. The other thing that can happen is in the cell, what do you call it? The cells themselves can become desensitized. They're so used to seeing that insulin key. They're like, no, I'm not going to let insulin in anymore. So even if you have insulin, so this is the problem with type 2 is why they don't always need necessarily insulin, is that their cells aren't sensitive to it. So the cells are literally denying or going, you can't come in when they're trying to get glucose into the cell. So in other words, diabetes doesn't always have to be about not having enough insulin. It can be that the cells are becoming resistant to the insulin, or in other words, even though the insulin is showing up, it's got the glucose attached to it, it's ready to open that door to get into the cell. The cells are saying, nope, you can't come in. So, effectively it can go one way or the other. Insulin either cannot get glucose into the cell or not enough insulin is being produced. These patients very rarely, unless they get really chronic, make zero insulin. They usually have some baseline of insulin. It's just not enough to meet the demands of what their body has or needs, or again, the cells are becoming resistant. The difference here too is that it's a gradual onset. So this usually happens over time. And usually these patients will have complications first before they even have any issues with any of the, where they're not just going in and being like, oh, wow, my blood sugar is high. It's usually that they're starting to experience complications. And when those are getting looked into, we find out that they have diabetes. So in other words, you can have this for years and not even know that you have diabetes and still be experiencing complications. In other words, the complications, like all that sugar in your blood over time, like even months, that there can be damage happening to you even without a diagnosis of diabetes. In other words, you don't have to wait to go into a crisis or to have that diagnosis for your body to be experiencing the pain and the discomfort and the problems that come with having too much glucose in your blood. There is genetic links, environmental factors, especially obesity. This is a lot more about lifestyle. And the good news is that, like I mentioned before, this can be improved just with lifestyle changes itself, oral medications and or insulin. Sometimes you need all three, sometimes you only need one, sometimes you need two. We'll talk more about it. So what does this patient complain about? So usually what's common is for them to complain about nothing. There's no problems. So some of them can have those classic symptoms, the polyuria, polydipsia, polyphagia. Most often they usually present with these systemic symptoms or complications first. So they usually show up with like an infection, an abscess, some sort of issue, or some like recurrent affections that they're just not getting better with. They can sometimes be losing weight. I know you're going to say, oh, wait, but I thought they were obese, but they're losing weight because they're not getting energy into the cells. So that weight loss does occur for them too. But usually these patients are more obese. Majority of them are or have some sort of alteration in their BMI. Just as a general, it's not a rule, but it's usually for these patients, the cause comes from lifestyle versus more like a deeper process like an autoimmune virus. And then they can also have some of those altered visions. Maybe they go to their eye doctor and their eye doctor says, hey, you're starting to show signs of, X, Y, and Z, like we'll talk about those kind of problems. Or they might start to have some numbness and tingling, so some paresthesias and stuff like that. But they're going to show signs of those complications sometimes first, not always. And again, this is not a rule, so we're not going to give you a question that's like, okay, patient has diabetes, which of these symptoms is going to happen first? Because every patient's different. So let's talk about diagnosis, and there's a lot of numbers here. And so I have some worksheets and stuff on my Google Drive, if that's helpful for you to kind of start breaking these down. So I think it's helpful when you're studying labs to always look at what is the lab actually telling you? Like, what is it trying to give you information about? Because it's one thing, like I can sit there and I can make flashcards and say, okay, glucose, fasting, random, here's the numbers. But if I don't really know what it means, what it's telling me, I'm going to be on the exam and I don't really know how to apply it to the question. And in this semester, we're all about taking questions and applying them to information or situations. And so you have to really know what these mean. So when we're talking about a glucose that's fasting or random, we're trying to figure out what is my blood glucose right now. And if it's a fasting blood glucose, that's telling me what is my blood glucose when I haven't had anything to eat. So like when I'm fasting, in other words, usually they make you like don't eat anything for at least 8 hours. And we want to see what your blood glucose is then. How is it managed when there's no food in your body? Then a random is going to be at any point. It doesn't matter if you've eaten or not, just randomly right now, like check your blood sugar. What is it? So it's going to tell us more about what's going on right now versus over time. There's also, we want to sometimes see how does the body react to glucose. So like, what's my insulin response? Is my insulin response working? Because remember, we talked about in a couple types of the diet, not couple types of diabetes, excuse me. We talked about how sometimes it's not an insulin problem. Sometimes it is an insulin problem, but sometimes it's not an insulin problem. So I'm trying to get where the problem is, because when we talk about medication and treatments, giving medications that are going to target whatever your problem is with your diabetes. Is it a cell problem? Do you have enough insulin? That's really going to help a lot. Does this patient need insulin, or can I manage them just on oral medications if they're type 2? What we're going to do is what's called an oral glucose tolerance test. And so if you've had a baby, you will know this test. They give you a big old sugary drink, and then they test your blood sugar. They test a baseline before you drink it, and then they test it like every hour. And effectively, they want to see how well does your body do putting how well is your insulin response getting glucose into the cell. So it's seeing how well your body deals with all that sudden rush of glucose. Then the one that's kind of a golden standard to diagnose diabetes, it's not the only one. We'll talk about diagnosing diabetes here in a minute. It's not the only one, but it's what's called a hemoglobin A1C. And effectively what it's telling me over time how my blood glucose has been. And this is super helpful because I'm sure you guys have experienced this. It's like coming up on time to get your like yearly doctor visit. And you're like, oh God, I got to eat healthy. I got to make sure I got to lose a few pounds, make sure, because the doctor's going to give me a hard time. So, a lot of times people try to cheat this. And so with a fasting or random blood glucose, I can eat good for a couple weeks, and maybe at the time it's a little bit better. But this one we can't cheat because it's for the last few months. Unless you impose something for a few months, it might be a little bit better. But most people can't keep up with those really strict changes that long. And effectively, because people always wonder, like, well, what the heck is a hemoglobin A1C? Effectively, what it's measuring is it's measuring the percentage of how much of my hemoglobin, which is why it has hemoglobin in the name, are saturated, or what percentage of hemoglobin have glucose on them. Now, normally, you should not be carrying around a whole lot of glucose on your hemoglobin. But when I have too much in my blood, and my blood's like, I need to get rid of some of this, I got too much, it starts piling it on that hemoglobin. And so it's a measure, and that's why it measures for 2 or 3 months, because you keep blood cells for about 90 days or so. And so it pretty much tells me how am I doing over the past few months. So that's a really good measure to see how they're managed, like if they have diabetes, how their glucose has been. But it's also really good to see how effective their medications are, or how they're doing, because patients come in all the time and they're like, oh yeah, I take my medicine, I'm doing great, but then their hemoglobin A1C, which is why I have this meme here, their hemoglobin A1C actually is like super high. Like, we'll talk about the normals on the next page, but it'll come in like a 13 or 14, and that's pretty high. So but it's one of two things, and you don't call the patient a liar, like, hey, you're lying to me, your hemoglobin A1C says differently, because it could be that their medicine's not working. Maybe they are taking it, but they need more, or they need a different medicine because maybe it's not targeted to them. But 9 times out of 10, they're probably not taking it like what they should be. Then we also want to see how their blood vessels are handling the sugar. There's a very strong connection between glucose, insulin resistance, and increasing cholesterol. So I want to see what their lipid profile is. And it also helps to see, are they stacking up those complications? Are they starting to get cardiovascular disease? And then those are just kind of in general for diagnosis and kind of managing it. But then during a crisis, what I'm going to do is I need to see, hey, are they in a state of acidosis? And we'll talk more about this when we get there. But I'm going to get an arterial blood gas, and that's going to tell me how they're doing when it comes to if they are in a state of acidosis, which we'll talk about. Don't worry, I know you guys love acid base. And probably by this point in the semester, you might have already learned about it, actually, because we're flipping around with the way that we're doing content. But anyway, it might also test their urine for ketones, which is another sign that they're in DKA. And we'll talk about this more when I get to the DKA section. It'll make more sense. But then we also might, in general, check to see if there's glucose in their urine, because a lot of times that's a sign. If I have a lot of times diabetics, they may have a little bit of glucose in their urine, but as a whole, if I'm pouring out glucose in my urine, it's usually a sign I have way too much, or I might be in crisis. So let's talk about some normal ranges, and these are from your book. The normal range is the fasting glucose 74 to 106. And, if you want to keep like a good range in your head, usually 70 to 100 is a good way to look at it. We're not going to give you one that's right on the border. We're not that mean, or at least I'm not that mean. I usually call out if they're trying to get a little anal retentive with some of these numbers. We can also check a random glucose. It should be less than 200. Because remember, the fasting is like when I'm not eating anything. When I'm not eating anything, 70 to 100 is a pretty normal blood sugar. Random, which means like, hey, I may have had food to eat at any point. I shouldn't have more than 200, greater than 200 milligram per deciliter blood sugar. Then that oral glucose tolerance test. Remember, we tested on a baseline just to see what it is before the sugar. Then we give a bunch of sugar, and then after 1 hour, they should, be less than 180, and after 2 hours, they should be less than 140. And then that hemoglobin A1C, which is that good measure over time, it should be somewhere between 4 and 5.6. Now, those are the normals, but just because someone's abnormal doesn't mean they are going to be diagnosed with diabetes. So the actual numbers that we look at, and I have a disclaimer here, we do not diagnose diabetes off one set of labs. We usually look at a few over time because sometimes things can come up. It depends on what's going on with the patient. So usually they have to have a hemoglobin A1C greater than or equal to 6.5. And if you remember here, this is 5.6 was the normal. So they have to have a higher hemoglobin A1C, a fasting glucose. And remember that we can look back here at the fasting was 74 to 106. It has to be greater than 126. And then an oral glucose tolerance test, it's going to be greater than or equal to 200. And so that's going to be after, after receiving the oral glucose. And I believe that's if it's after 1 hour, if it's greater than 200. We also can just look to see if they have the classic symptoms, that polyuria, polydipsia, polyphagia, and a random glucose that's greater than or equal to 200. And I know that that's a lot of numbers. I gave you a lot of numbers in the last 2 pages, by the way, but just keep in mind, like, this is how we diagnose diabetes. This will be more that what you want to kind of keep your eyes on, but it's good to know what some of these normals are because they can show up, and they can also show up in a later exam. I know you guys love when we bring up cumulative material. So what do we do to regularly monitor diabetes? We regularly do serum, which anytime you see the word serum, it means in the blood. We do check those, like usually like patients that are in the hospital, they'll get like a morning chemistry and that will have a serum glucose on it. And keep in mind that the serum glucose, I'm sorry, I'm getting thirsty here. But don't worry, I don't have that polydipsia. My cells are not being dehydrated. I'm just talking too much. So the serum or in the blood glucose is usually higher than the capillary. You might be thinking, but why? So if they're just drawing my blood like from my arm, I'm going to have more sugar there than I'm going to have in my fingertip. Because remember, in the fingertips is where I'm dropping off. So that's why it might be a little bit lower in the capillaries, because I've dropped off some glucose to my fingertips. Something to kind of just know with that. Like I said, while normal is around 70 to 100, keep in mind when people are sick and in the hospital, their blood sugar is going to be higher. So like, if you're on an exam and you see someone has a blood glucose of 112 and you're like, oh my God, this is abnormal. Usually in real life, we don't start giving insulin until the blood glucose is even around 150. I mean, every hospital is different. Some sliding scales will start around 130, but just keep in mind, for a patient having like, when you're a nurse and you're out in the hospital, if you have a patient who has a blood sugar of 112 and you're like, it's elevated, it's above the normal range, like, calm down, like it's going to be okay. So, because everyone's blood sugar is a little bit higher, like half of the medicines we give have dextrose in them. So it might be higher for that reason. Patients are going to be more sick. So when you're sick, your body secretes more glucose or lets go of more from its stores because it needs more energy to fight off whatever it's battling. So just keep in mind, like when if you're trying to say, because like, again, like some of students struggle, they're like, yeah, but when am I going to need to take action? And we're going to talk more about it when we're talking about hypo and hyperglycemia. But keep in mind, like, really, not for diagnosing diabetes, but let's say someone has diabetes, like I really don't even start treating it till it gets above like 130, 150. So if that kind of gives you a little bit of a ballpark in your head, and I'm not saying this is a rule, but I want you to kind of keep this in mind when you're treating patients and taking care of them. And just, when you're looking at an exam and you're looking at a question, if they have a blood glucose, let's say even of 133, like, okay, well, maybe they need some insulin, but that's not crisis level. So if this helps you, like, to kind of start saying like, okay, when am I going to start to be worried about a patient? When it starts getting up around 150, 180, then we're getting in the 200s, like that's where it's really starting to get high. And we definitely want to keep that down. And we'll talk about this later, but the goal in diabetes is to keep their blood sugar stable, because especially just because it's expected in the hospital for it to be a little elevated, it doesn't mean that I'm like, oh, it's 250, but that's okay, they're sick. What I'm saying here is that we want to keep it stable in order to help prevent complications. The more glucose I have, the more injury that's happening to my cells, the less I'm going to be able to heal. The more my blood vessels and the flow to wherever the problem is going to be decreased because of all that extra sugar. Lots of studies have shown that the higher your sugar is, the harder it is going to be for you to heal. And like it can affect so much. I'm not going to get into that. But so effectively, what I'm trying to say here is it's going to be okay if their blood sugar is mildly elevated when they're in the hospital. But once we start kind of getting up into the 150s, 180s, etc., that's when we're going to start really needing to treat that blood glucose. Like that's kind of our threshold for treating. And then when we're getting up, 180s, 200s, we're starting to kind of be like, okay, we really need to get something done where it's a little bit more serious. It'll make more sense when we talk about crises and things like that as well. So glucometers, this is what we call a POC, or a point of care. You might see those words like a POC glucose means a point of care glucose. That means that when the tech goes in and pokes their finger, we can do them at the bedside, or that can be done at home. So this is like a self-monitoring, and patients need to be taught how to do this. And you'd be surprised how many patients that have diabetes that have never used one of these and do not know how to use these. Then there's also what are called continuous glucose monitors, and that's what's in this picture. And what this is that it is a monitor that has an internal sensor. It literally goes in and can tell what your glucose is, continuously. It can give a reading like every 1 to 5 minutes. And the great thing is they can actually send them to handheld devices now. And I usually reference when I do this lecture, my cousin I have that has type 1 diabetes, really, really brittle diabetic. And her mom, when she would come to visit me, would have it. And there was one time her mom was coming out visiting me, my aunt, and she was looking and her phone like alerted her, hey, her blood sugar's like 40. And so she was calling her and saying, eat a banana, eat a snack right now. You need to, your blood sugar's tanking. So yeah, so definitely have to keep a close eye on that. And usually these are used in conjunction with an insulin pump, which we'll talk about a little bit later. But it just helps to kind of, it helps to keep a much more fine controlled balance to people's blood glucose. So let's talk about tips to check a capillary blood glucose. So if we're going into the room, and I said the tech's going to go in and do it, but nurses can do it too. As an ICU nurse, I do my own blood sugars. And it just depends on kind of where you're working, if you even have techs. So just know you need to know how to do this too. So you can't always put it off on someone else. Know that alcohol swabs can alter results. That's why we always want to wipe out. Wipe off after because we clean, we poke, and then we want to wipe off that alcohol because it can alter the results. We want to warm their hands if possible. I'm not saying you need to spend an inordinate amount of time doing this, but especially if you're having trouble getting blood out, you might. Sometimes if I have a patient with really cold hands, I'll wrap their hands in a warm blanket before I go in, if I know I'm needed to go in and do it soon. You can let their arm hang dependent, and you're going to see this word dependent a lot this semester. So dependent means down. So it doesn't mean you need to put their arm crazy in the air like this, but like if they're in the bed, you can lay them down and kind of like let it hang down to help to allow for better flow to those fingertips. Try to use the side of the finger, not the center, because the center is where a lot of the nerves are. And do not milk. Now I know people are going to say, well, I see people doing this all the time. Yes, they do. But when we say do not milk, we just don't want to squeeze it like crazy. It's one thing, like I kind of push to get a little bit out, but I'm not sitting there like milking it like crazy and getting nuts with it. That can damage the blood vessels and cause change. Like it can change the results sometimes from the squeezing because other particles can get in there. Anyway. So what's the goal in diabetes? Like I said, my goal is euglycemia, and I don't mean like euglycemia, I mean like EU glycemia, which means that I want to have a steady and stable blood glucose. I don't want to have a lot of highs or a lot of lows. Like I pretty much want it steady. And so that's why, like, keeping the blood glucose, like even though I was the normal 70 to 100, I've never seen many diabetics. I've seen very, very few diabetics that are actually able to maintain that in the hospital. Now at home, maybe so. But we really want to keep it where they're not having too many highs or too many lows, because lows are actually sometimes worse than highs. We'll talk about it. The higher the blood glucose over time equals more complications. So the longer that my body has to manage, sustain, or deal with a whole lot of blood glucose, the worse the outcome is. So what can we do to help them to meet this goal? So what I can do is we do a lot of medication management. There'll be a separate PowerPoint over medication management, insulin, oral medications, depending on the type of diabetes in the patient. Dietary and lifestyle changes, weight loss can help if it's indicated. We'll talk more about that coming up. Exercise is key for these patients. It can help so much managing the blood glucose. I'll talk more about that. Regular education, and again, I'll talk more about that soon. And then regular checkups and monitoring. So effectively, we need to, like, you're never, and I know that you're going to hear, you might have heard people say, hey, I got cured of my diabetes. There is no cure for diabetes, but it can be managed, and it can be very manageable if managed well. So let's talk about how we can manage it. So we can manage it through nutrition. So if you have a stable blood glucose, like we said, there's less complications. So when we're doing a diet for diabetes, we're not just doing a diet to treat the diabetes, we're doing a diet to treat the complications. And like I mentioned before, there's a lot of cardiovascular complications. So therefore, this patient needs to be on a diabetic, which is like a low carb diet, but they also need to be on a heart healthy diet. So when you're looking at, answer choices in the test, make sure you're not just thinking about what has sugar in it, but what's going to be heart healthy. I'll kind of be describing what that looks like in the next few slides. Effectively, I want a stable blood glucose. I want to decrease their cholesterol and prevent cardiovascular disease and other vascular complications. So I can do that by managing their carbs, and they're going to be individualized. Most of the time in the hospital, you'll see like an 1800 ADA diet. So that's 1800 calories. But they're going to maybe get only so many carbs, or when they're selecting their menu, you may see that they only get to select so many. 25 to 30 grams of fiber per day helps prevent complications, because a lot of fibers are going to be those really healthy fruits and vegetables too. Dietary cholesterol, we want them to take in less than 200 milligrams per day. And then kind of this is the cardiovascular part of the diet. Limit to their saturated and trans fat foods. Protein is going to be individualized just depending on the patient, but protein is a great way to stay fuller longer and going to help to build up some of that immune system and stuff too. And then alcohol should be done in moderation with meals. Women can have 1 a day. Oh, I know, it's not fair. Men can have 2, and because alcohol can actually cause hypoglycemia. And this is very confusing, but alcohol, I was going to say the liver, where alcohol is processed, it controls how much glucose that you are getting rid of, et cetera. And when with alcohol, it can mess with how well you are releasing stored glucose. And that's all I'll say about that, because otherwise it gets confusing. But just know it all has to do with the liver and its glucose storing capabilities. So what foods are good for this diet and which should I avoid? So we should eat lean meats like baked chicken, fish is good, low-fat dairy, because we like the low fat for the cardiac, whole grains, that's a lot of that fiber we want, leafy green veggies, legumes, some nuts, things like that. We want to avoid things that are fried, processed, butter, cake, biscuits, beef. That red meat's really not good for cardiovascular. And then any full-fat dairy like whole milk is not going to be the best. So carbohydrate counting, this is kind of what I was talking about, is that some patients in the hospital, you're going to see on their meal tray or on their diet where it says like, hey, this is how many carbs for each section. But this is kind of how something that someone set up, to help diabetics, people that are diabetic, to better plan their meals around their carbohydrates. And to stay in kind of like a carbohydrate allowance. So all carbohydrate needs should be individualized. Every patient's going to be a little different, but most adults are really going to have about 45 to 60 grams per meal of carbohydrates. This is kind of an example here. So like the eggs have 0 carbs, this has 15, this has 4, this has 15, 12, etc. And so you kind of add them up to get about where you want to be for how many carbs, etc. And you don't have to, like, we're not going to give you some crazy question about, counting carbs in this way, but what we might give you is a question that's asking you to figure out how much insulin to give. So the reason that you as the nurse might need to understand what's on their tray, how many carbs, and don't worry, you'll never have to calculate it. The nutritional services, they have usually on the ticket will say how many carbs everything is. All you have to do is just look to see what the patient actually ate. But effectively what it's looking at is it's looking at you know, before a meal, I'm going to check a patient's blood glucose and I'm going to say, okay, their blood sugar is 186. I need to give this many units of insulin. But here's the thing is, remember how I said I don't want those highs and lows? I can treat the patient's blood glucose of 186, but if they're about to eat, they're about to get an influx of carbs, and that's going to cause their blood sugar to go up even higher. So what we call carbohydrate coverage on a sliding scale means that I'm going to give additional insulin to factor in how much they're about to eat. So in other words, I don't, and you're going to see some nurses do this after they eat, but really you're supposed to do it before. So knowing kind of how the patient eats, or even asking them, hey, how hungry you are, what are you going to eat? I can go in and I'm going to see effectively, I'm going to guess. So let's say that this was the patient's tray and they say, hey, I'm going to eat I'm just going to eat the raspberries here because that's all I'm hungry for. Okay, fine. So then what I would do is I'd go to my sliding scale, and let's say that the order said, I'm going to give 1 unit of insulin for every 15 grams of carbs. So again, let's say they had a blood sugar 186. I need to give them 2 units for that. I'm also going to factor in the fact that they're about to eat these raspberries. So I'm going to give them an additional unit of insulin in order to cover those raspberries they're about to eat. Now, that's super confusing, but luckily for you, I have a practice problem, and maybe it'll make more sense when you see it. So, so let's say that this is kind of the same thing. So it says a client has orders for sliding scale insulin and carbohydrate coverage. How many units of insulin should the nurse administer based on the following scale? So we're using the scale over here to the left, and they're receiving this insulin. And then it says give 1 additional unit for every 15 grams of carbs. So let's see, my assessment findings, my blood glucose was 215. So if you don't know how to do a sliding scale, by the way, effectively all the numbers over here are what the blood glucose is. And then I find where my number falls. So 215 is going to be right in here. And then I'm going to go to how much insulin I need to give. So it says here for a blood sugar of 215, I need to give 5 units of insulin. Great. Seems pretty simple, right? However, the client is, it says client at 45, but I think it's supposed to say 8. I'm sorry, my typing is just so off point. But this is me. That's why I don't actually edit these videos and try to make them perfect, because this is me. I'm just a goofball and I can't type. So you have to take it or leave it. So anyway, it says the client ate 45 grams of carbohydrates. And then in my order, it says give 1 additional unit for every 15 grams of carbs. So if they ate 45 grams, that is 3 additional units that they're going to need, because 45 divided by 15 is 3. And then they're already receiving 5 units plus the additional 3 for their 45 grams of carbs. So 5 plus 3 is 8. 5, 6, 7, yeah, 8. Just double checking my math. So 8 is the correct answer here. It's been a long semester. I'm doing so starting some of these before the summer. So if I see more relaxed in some of the future ones, that's why. And so at the end of the day, hopefully this makes sense now. Is effectively what I'm saying is that we give insulin to treat the blood glucose normally, but sometimes we give additional to treat what they're about to eat. So you could have a problem like this on your exam. So, and I have some practice on my Google Drive if you would like more practice. So let's talk about exercise. So the benefits of exercise is, of course, to lose weight is one. And with weight loss, it helps with some of that insulin resistance. It helps to decrease some of the other complications and problems they're having. It definitely helps as a whole and many different levels and spectrums. Exercise also helps to lower blood pressure and blood glucose for up to 48 hours after that exercise is completed, which is super helpful. Exercise also decreases their need for medications, so they may need less medications because their blood glucose is being managed better because just from exercise alone. It can also help with some of those cardiovascular problems. It can lower your cholesterol, that's your LDL, your triglycerides, and then it raises your good cholesterol, which is your HDL. Don't worry, you'll learn about that in cardiac. And it also decreases your insulin resistance, which, we talked about is where the insulin cannot get into the cell because the cell is like, nope, I'm not opening my doors for you. And then as a whole, it also improves circulation. And since diabetes is it's a vascular issue as well, and those blood vessels are hurting, circulation helps. So a couple general kind of things to consider before exercise, or things to teach your patients, is you want to teach them to exercise after eating and to check their blood glucose before exercising. So in other words, you do not want to exercise before eating. You need to have some glucose in your body because you're about to burn some glucose. And this is something that students find very confusing, but your blood glucose actually goes down with exercise. A lot of people think, oh, I'm so stressed out, my blood glucose is going to go up. But no, you're burning your energy and burning that glucose during that exercise. So you always want to have a good like stockpile of glucose ready to be burned. That's why you want to eat first. And then you want to check your blood glucose. And if your blood glucose is less than 100, you better not be doing any exercise yet. Eat a snack and then wait till your blood glucose gets above 100. If you're type 1 diabetic and your blood glucose is greater than 250 before exercising, do not exercise, drink water, because you could be going into crisis. Especially, oh, sorry, I should put the caveat here. So you're type 1 diabetic, blood glucose greater than 250, and you have ketones in your urine. That's usually a sign you're going into diabetic ketoacidosis, which we'll talk about here shortly. We definitely do not want them exercising, and they need to drink some water to rehydrate. It'll make more sense when we talk about that. But yes, we definitely want their blood sugar high enough to exercise, but we don't want it so high that if they're about to go into crisis, because what else happens when I exercise? I get dehydrated because my body is using all my water stores. I'm going to teach the patient to wear good footwear, because we're going to talk about foot problems that you can have with diabetes later. And usually the general recommendations is to do about 30 minutes of moderate intensity. And moderate intensity means that, I would sometimes go to the gym and read a book on the bike. And if I can sit there and read a book comfortably, I'm probably not doing moderate intensity. If I could talk on the phone comfortably, I'm probably not doing moderate intensity. But if they're doing moderate intensity, they can't really talk comfortably with someone else while they're doing it, that's moderate intensity. We usually like them to do aerobic physical activities about 5 days a week. There are some alternative treatments like bariatric surgery. So like a lot of times bariatric surgery, which we'll talk about in the last section when we talk about GIGU, that can help to decrease comorbidity. So sometimes having a higher BMI, but also diabetes, can help to qualify you to get a gastric bypass, things like that. It can help you to achieve more glucose control and things like that, but only if done with permanent lifestyle changes. It's not as helpful if you're just doing it by itself. A lot of times people think bariatric surgery is a quick fix, like I just need to lose 50 pounds and then I'll be okay. But if you're still eating and acting and interacting with food and life in a way that is not supporting a positive blood glucose, that's going to make things harder. There's also what's called an islet cell transplant. This is great for people with type 1. And what it is they effectively take someone's like a donor cells of islet cells, which is what makes insulin, and they transplant it into your liver. So effectively, since your pancreas has some problem like autoimmune, viral, something's going on, your pancreas isn't working, they transplant these islet cells that can make insulin into your liver, and it pretty much starts secreting insulin from your liver, which is kind of crazy, right? And that can definitely help for people that don't have any insulin. Then there is a pancreatic transplant. This is for type 1 diabetics. And a lot of times they end up needing a dual pancreas and kidney, because usually by this time, a lot of them are on dialysis. We'll talk about that. That's what my cousin that I told you about, this type 1, she is still waiting to this day on her pancreas kidney transplant. And so hoping maybe by the time that you guys are watching this video, she might have gotten one. So it can eliminate the diabetes, but it cannot reverse the damage that was always done. So this kind of goes back to what I was talking about before, is that we can improve their blood glucose right now, but it can't stop the damage that's already happened to their blood vessels and to a lot of their organs. So keeping in mind, we want to treat the problem, which, like I was just saying, is the high blood glucose. We also want to prevent complications. So the diabetics are at higher risk for all the 3 I's. That's infection, impaired skin integrity, and injury. And like I said, they can experience complications before they're even diagnosed with diabetes. So that's why I'm kind of getting into how important teaching is. And I have to teach them so many things about how to prevent complications, how to prevent infection, how to protect their skin, how to prevent injury, especially to their skin as well. So regular monitoring for complications is going to be key for these patients. You want to teach them yearly to get an eye exam with their eye doctor. They're also going to need yearly testing for albumin, and this is what's called albuminuria, It has the urine in it, but effectively it's looking for protein in the urine. Oh, sorry about that, getting choked up. And so effectively what albuminuria is, or looking for protein in the urine. The purpose of that is to see how the kidneys are doing. The kidneys are really sensitive, like I said, to getting good flow, and they're easily damaged by diabetes. So I'm going to need yearly testing to see how they're processing. Normally, I don't let go of protein in my urine. So if I'm letting go of protein, I've got a serious problem, or not serious, I don't want to make it sound like horribly scary, but they're probably going into kidney failure. So in other words, if I'm letting go of proteins into my urine, then that's usually a sign my kidneys are starting not to work. So we check their eyes for complications. We check their urine to see if their kidneys are functioning. They need regular teeth cleanings because they're going to be higher risk for getting infections and problems with their teeth too. And teeth are the gateway to your heart. So I know that's going to sound weird, but it's true. Like if if my teeth are not healthy, I'm at higher risk for cardiovascular disease. We also, speaking of which, need to monitor their cardiovascular health. That's through regular blood pressure checks and checking their cholesterol levels as well. Just kind of seeing when these things are coming up. And then daily skin and foot checks, and I'll talk about foot education on a different slide. Teaching them how to look at their skin and to look for problems, because a lot of these patients, like I said, are obese. They can have like breakdown and other problems under folds. And then also they commonly they don't have as much sensation. And so they can commonly get skin breakdown, ulcers, and not even know that they have them. We want to also tell them to take measures to assess for and prevent infection. So it's going to be things like hand hygiene. They need to know, what are the symptoms of infection? What does infection look like? How will I know if I have a wound if it's infected? And then staying up to date with immunizations, especially, they should be getting their yearly flu. They're going to be at high risk for pneumonia. So they usually get the pneumonia vaccine and any other vaccines like with COVID and everything like that. They've had to stay, most patients with diabetes are considered very high risk for getting COVID and for dying from it. So they're going to be top of the list there as well. We were going to do whatever we can to keep them up on their physical exams, prevent and find complications, and then also prevent infection, etc. So general education, teaching them that compliance is key, compliance with their medications and with all of those preventative things that I talked about before is going to be so key. Always have medicine and snacks on hand, because they never know what's going to happen when they're going to need them. I've, been friends with some people that are some pretty brittle diabetics, and there's been times they've gone into crisis. They always have to keep, you don't have to have a fanny pack if you don't think fanny packs are cool, but you got to have something on hand to help to make sure that you can get that glucose in. They also have to know the signs of when their blood glucose is high and when it's low. So we'll talk about this here in a minute, but high is going to be like classic diabetes symptoms: polyuria, polydipsia, polyphagia. That's going to be some of those really common things. And then low, they should be thinking like hungry, tired, and irritable. And we'll get more into what those signs and stuff look like, but that's what you could teach your patient. Sick day education. So the one thing that a lot of students find confusing, because a lot of times when people are sick, they're not eating, is that we want to tell them never stop taking their insulin, even when they're sick, even if they're not eating. So I was reading my words and I was like, wait, I was making sure I didn't do a typo there. So always take your insulin even when you're sick. Because here's the thing. Remember how we talked about with exercise, your blood glucose goes down. But remember we talked about when you're sick, your blood glucose goes up. So even if they're not eating, their blood glucose is going to be up fighting whatever they're fighting. So they still need to keep taking their insulin. They're still going to check their blood glucose. They need to take their insulin if their blood sugar is high, because I'm not saying every person who's sick always has a high blood sugar, but usually they do. But a lot of times people are like, well, I'm not eating, so I have no reason. They think, oh, I take insulin when I eat, versus I take insulin when my blood glucose is at a certain level. Because we really, again, like I said, when someone's sick, we want to manage that blood glucose. They're going to need to check their blood glucose more frequently, usually about every 4 hours when they're sick, and stay hydrated, because they can easily go into crisis if they do not stay hydrated. Because remember, blood sugar's up. And if I'm dehydrated because I'm not eating or drinking anything and my blood sugar's up, I'm high risk to go into crisis. And we'll talk about crises soon. But that's some of the important stuff. Now, when we get into oral medications, you're going to see that some of them are going to say, hey, you have to eat in order to take this. So this is not say, does not say, do not stop taking any meds. It just says insulin. So they're gonna check their blood glucose. If they're on the oral meds, there's going to be some that they cannot take if they're not eating. So we'll talk more about that, but just keep in mind that this first one really just applies to insulin. It's not talking about all diabetic medications. So foot care, we're going to tell the patient to examine their feet every day. And they have to examine their feet every day because it's so easy. Like, you and I, we can wear like a pair of shoes. They're a little too tight. We get kind of like a little like chafing mark or something on our feet. No big deal. These patients, they get a chafing mark and then 2 weeks later, like they're getting part of their foot cut off because there's something that's not healing. So that's why they need to check their feet every day. So they need to learn. And some of these patients, they're obese. They can't even see their feet. So we have to give them the tools they need. Some of them need mirrors. Some of them need someone else to check their feet for them. But there has to be a way, a place, or a time for them to check their feet daily because little things can come up. Because I mentioned this before, but we'll talk more about when we talk about complications. But the issue here is that they effectively cannot, it's a two-part thing. They can either have neuropathy, which is where they're not feeling, they're not feeling, they have lost, I'm sorry, I can't get a sentence out here. They have lost sensation to their limb. And so effectively, think with neuropathy, they're going to complain of numbness and tingling. And so they're not feeling as much. And that's a result of the fact that they have so much glucose in their bloodstream that it breaks down the nerves that are down there to tell them, hey, you've got a wound down here. So those nerves that usually would send a painful stimulus stop doing it. So they can have decreased sensation or no sensation. Some people can't even feel their feet that are diabetic. And so that's part of the problem. The other thing that they can have is peripheral artery disease, because this is commonly tied with diabetes, where they actually literally have decreased flow to their feet. But regardless of whether it's just like they have decreased blood flow, they have decreased feeling, they're going to be at higher risk. So we examine their feet every day. We want them to wear comfortable, well-fitted shoes. So they're going to need to make sure, a lot of times they work closely with a podiatrist. And the podiatrist also often clips their nails. Now, they don't always, not every diabetic has to go to the podiatrist to get their nails clipped, but I'll give you a little real life advice to never clip a diabetic's nails, because they can so easily have issues that I would never in my life clip a diabetic's toenails, because there's just such a high risk for infection and problems if something goes wrong. Now, on a nursing school exam, you might see something that tells them to, like it says here, trim your nails straight across. So if you're going to clip your nails or trim your nails, do straight across. But a lot of them are going to go to a podiatrist because it's just safer and they can have their feet managed with them there. They might need orthotics, other things like that. We want to avoid applying anything that's very hot or very cold, because if I'm diabetic and I can't feel this, I don't want anything very hot or very cold because I'm not going to know it's very hot or very cold. So I have to be very, very careful with temperature extremes with these patients, because they can have damage and not even know it because they can't feel it. Never should walk barefoot. They should always have something on their feet, shoes, etc., to protect, because if they step on something, you and me, we're going to be fine. We get a little cut, it heals. They cannot heal, not the way we can. And every little infection to them becomes massive. And they should apply moisturizer or lotion to surfaces of the feet, but not in between the toes. In between the toes, there's going to be very, very high risk for like fungus and stuff like that, because it's more of a moisture area. So we do not want stuff in between toes. We already talked about clipping the nails carefully. Usually they go to a podiatrist, or they're going to go straight across. And then they should avoid prolonged sitting, standing, or crossing of legs, because that's going to further decrease their circulation. So a couple other things here. It just says wash your feet daily with lukewarm water and soap. So we don't want to put anything extra. We don't add alcohol, scrubs like to clean the feet. We don't want to do anything that's going to dry out the skin. Remember, we like that moisturizing lotion to keep the feet from getting too dry. It says to dry your feet well, especially between the toes, because we do not want that moisture in between the toes. Talked about that. Check every day. Like you can see them here with the mirror, looking at everything. Look for any blisters, cuts, or even redness can be a sign. We talked about that. Change socks daily, and we do not want dirty or tight socks. We don't want to do anything that's going to decrease that circulation. Never work barefoot. And then look for cracks in your shoes and stuff like that, or something that you might not be able to feel. So yeah. So it looks like the next slide is getting into the highs and lows of blood glucose. I think that this has been a pretty long video, so I'm going to cut this as part 1 of diabetes. So this was a good introduction, a little lengthy, but hopefully for those that are looking for length, this is what you're looking for. I'll see you next time.